Welcome, and thank you for joining us today. This is one more PPMD's Pat Chats, and today we have Dr. Deip Nandi from Nationwide Children's Hospital. Some of you may know Dr. Nandi or have seen him at Nationwide, but I'd first like to start with, Deip, would you introduce yourself?
Sure, Pat, so nice to have you, so nice to be with you here this morning chatting. Thanks so much. Also, just can't say how thrilled we are to continue to strengthen our ties with PPMD, especially at Nationwide and through the Action Network. So to tell you a little bit about myself, I'm from Texas originally. I did my undergrad at Harvard, med school at Duke, residency at the University of Michigan, and then I did my cardiology fellowship and advanced training in cardiology and heart failure and heart transplant at the Children's Hospital of Philadelphia, CHOP, as many of you probably know, before moving here to Nationwide, where I've been here for the last 6 or so years. Now the director of our advanced cardiac therapies program. On a personal note, while I don't have a family member afflicted with muscular dystrophy, my father, who had the pleasure of having lived with me for the last 4 years of his life, had a neuromuscular disease that was akin to Parkinson's, but very different and didn't respond at all in the same ways. So I know a little bit about the maddening and frustrating world of unclear diagnoses, unclear paths forward, and what neuromuscular disease can do to patients, caregivers, and families. So it's a real pleasure to be able to help take care of patients like the families we take care of now.
Thanks, Deip. I think that is one of the biggest struggles we have, especially when it comes to the heart, because we don't know, some children have more severe disease, some children have some young men have very healthy hearts for a long time, and others not very healthy hearts. Can you shed a little light on that? And also the second part of this is, what is the Action Network going to do? What is it set up to do?
Sure. So you're right. We do not well understand the cardiac phenotype in the dystrophinopathy patients in general. The preconceived notions of the differences between Duchenne phenotype versus Becker phenotype are slowly starting to erode as we recognize, especially with the cardiac phenotype being so drastically different between the two. Obviously, Duchenne patients who may have really preserved cardiac function for many years, or Becker patients with very nice skeletal muscle strength who have very early cardiac disease, or patients with more standard Duchenne who have very, very early cardiac disease. It's recognizing that these patients don't necessarily fit a standard phenotype or a standard book is very important, because we probably have a lot to learn from these outliers, as it were, and to understand what is changing in the cardiac phenotype. Because we're more and more recognizing this broad variety of cardiac changes that can occur and the variability of time frame of that, it's very clear to us that we need to provide a lot more careful and clear diagnostic review of patients starting from an early age, so that we can capture these more atypical phenotypes, as well as not rest on our laurels regarding patients who may appear to have a really nice cardiac phenotype for some period of time. So it's really looking very carefully. And then the contra to that is not just looking. Worry without action is not the same. One must also think about what are ways in which we can minimize or slow down these cardiac phenotypes if we believe that they're going to come into fruition. And that's where we're starting to realize and push more for early initiation of possibly preventative therapies. So to jump into how Action's role in that is moving is really trying to help provide a national infrastructure for cardiologists and providers who are taking care of dystrophinopathy patients to learn best lessons, best data, and disseminate those best lessons and best data in a most comprehensive manner that we can. So the Action Collaborative, which stands for the Advanced Cardiac Therapies Improving Outcomes Network, started several years ago out of a core group of programs initiating with our colleagues down in Cincinnati, but now include essentially many of the major programs throughout North America and into international groups as well. While the initial focus was on quality improvement related to ventricular assist devices, it has now spread, and we're now focused also on heart failure in general and in the muscular dystrophy population in particular, the DMD population. So I'm very lucky to work with our co-leaders for Action, both Angie Lortz and David Rosenthal from Cincinnati and Stanford, as well as our specific leaders with Action, including Chet Villa from Cincinnati, as well as Linda Kripe here at Nationwide Children's, who many of you probably know well as well. I can go into more on the details of what Action is looking forward to do, or I can take a pause.
Yeah, well, first of all, I'd love for you to tell us about natural history and how are you going to sort of understand or better understand the natural history of this disease? What is that a first step for the Action Network in Duchenne?
It sure is. So the current era of cardiac care is really a vastly different landscape than perhaps the initial natural history studies. We do have medicines that may have good effect, but perhaps incompletely used. We also have a much better understanding of respiratory disease, of assessment of the neuromuscular strength from our wonderful neuromuscular docs, physical therapy, and occupational therapists, as well as probably a more widespread use of steroids prevention of skeletal muscle fibrosis, fibrofatty replacement. So the lessons we need to be relearned. What does cardiac disease look like with a modern cohort? With potentially the more modern medicines that we're using across the board. So Action Network is set up to collect data for a new natural history study, which will be funded largely in part to PPMD, so that we can start collecting this data more broadly and at many, many institutions. While collecting the data at large centers is important, we're also not collecting data, losing potentially data from many of the smaller institutions that aren't directly involved necessarily. And so by collecting data from everybody, we're going to have a much larger volume of data that we can get moving forward. We're going to initially start with patients age 10 and older of any dystrophinopathy sort. And we'll be collecting data for those who have dysfunction even earlier. But this data is not purely cardiac data. We'll be collecting data, yes, on their function, yes, on their labs, and yes, their medications, but we'll also be collecting genome, pulmonary, and functional assessment data as well to get the best global picture that we can. And then we'll be following this data longitudinally into the future. So by doing so over a short period of time, we're going to collect a large amount of data. The initial version of the Action database, just limited only by honestly funding and time, focused on patients with moderate to severe dysfunction of the dystrophinopathies. And in a few short months, we collected over 100 patients, and those patients will of course be part of the future database version as well. But if we can get 100 patients with moderate to severe dysfunction, that gives us some clue and some insight into those patients, but does not necessarily provide us with that larger cohort. What's the denominator? Everybody else, who is becoming dysfunctional, who is not? What is the rate of that decline? Again, can we draw inspire lessons to be pulled across all of those cohorts? So that's step one, getting that general natural history data over the next few years here. I think we're poised to really do a good job with that and get that fully put together. But at the same time, I think we'll also be poised then to really start doing subgroup analysis and really drill down into what is working. Are there clear mechanisms, there are clear patterns of care that are leading towards delayed onset of dysfunction, delayed onset of fibrosis. And for those who do have that dysfunction or fibrosis, can we find that there are truly patterns of care that are helping slow that down even further? And then where are there successes? Where are there programs and patients that are having dysfunction but are being effectively treated? Who is an effective and safe VAD candidate? Who is an effective and safe transplant candidate? These are all things that we can start to look at by collecting data from everybody, or as many programs as we can at least.
And so Deip, you're looking at cardiac MRIs. I know, and I've heard from some families as cardiac MRIs are read, that sometimes at least the interpretation that a family receives maybe uses different words or feels like to them, reads like to them, is a different interpretation of an MRI based on a different institution or different reader, for instance. Can you talk to us a little bit about first the importance of cardiac MRI, and second, why, or do we receive different reads from different institutions?
Sure, that's a great question. So as not an MRI cardiologist, I don't want to misspeak too much. My colleagues will be very upset if I mischaracterize, but the MRIs are just so very important. It's increasingly evident that we are seeing signs of MRI changes prior to the onset of dysfunction. And that window of MRI change prior to the onset of true cardiac dysfunction is probably the best, or at least the last time point we might have to positively affect the myocardium. So recent pathology studies looking at actual hearts of dystrophinopathy patients have really cemented, for me at least, the idea that the cardiac muscle is akin to skeletal muscle, and there is fibrous replacement and then fatty replacement of the tissue. And once you are truly through to a fatty replacement of the tissue, there's very little cardiac muscle help that we can provide with oral heart failure medications. We're well past any sort of prevention. So the signal that we can see on MRI that we have no other ability to otherwise is that presence of late gadolinium enhancement. So when we do a cardiac MRI, that's what the IV is for, to have the gadolinium injected into the veins, and that can show us where there is late enhancement, which is alternatively called fibrosis on some MRIs, or it's fibrosis imaging. And that might be a bit of a misnomer. It might not just be fibrosis. It may be fibrosis and fibrofatty replacement as well. So it doesn't necessarily tell us the degree of progression, but certainly the size and change of the fibrosis within the heart on the MRI is very, very telling towards predicting what the function is going to do in the coming years. So that's one aspect of the importance of the MRI. Another aspect that I think is just relatively underlooked is the idea simply that it's the best imaging that we can do of the heart. Many of our patients are, of course, wheelchair bound, may have significant respiratory disease, and may have significant neuromuscular related scoliosis. So positioning them for really pristine echo images can be very unclear. Interpreting an echo, even if you have reasonable pictures of somebody who's in a seated rather than a recumbent or supine position, it's very difficult, and you may be misinterpreting what you're looking at. This is why for many years, one of the easier views to get of the heart is something that can show us a shortening fraction as opposed to an ejection fraction. And interpreting those two data points are very, very different. So an MRI gives us the best information of the heart. That's not to say that the echo doesn't add a lot and can be done more quickly and more in a more mobile manner, especially for patients who may not be able to tolerate laying flat. But the echo is only part of the story of the function. There's some other newer parts of MRI that I think are going to show more utility. My colleagues here, including Dr. Hoare, of course, have shown changes in strain of the heart, strain and how the heart deforms to actually squeeze. That's also much more readily accessible on an MRI for Duchenne patients than echoes, and that strain may also be another important point. But the MRI, it's overall very, very important. The second part of your question, I'm sorry.
The second part is, why would you get one reading from one institution and then maybe use different words by a different reader?
Yeah, absolutely. And the answer is we're all different and we all do things slightly differently. And that's a problem. I'm a firm believer in quality improvement, and the basis of quality improvement in all of our cares is standardization of care, so we can see what we're doing and how and what the impact of small changes can be. And if we're all doing something slightly different, it dilutes our ability to understand the care that we're giving. So there's wide variability currently in how MRIs are done and how they're interpreted. Some folks are using sedation to undertake MRIs, and I think that drastically changes some of the hemodynamics, because your blood pressures are lower, can make some hearts look more dysfunctional. And I've seen that many times in some patients who come for the sedated MRI at a different institution and then receive an unsedated MRI at another institution have drastically different function. As I just said, that late gadolinium enhancement, or LGE, some places call fibrosis. Maybe it is fibrosis, maybe it's not. There can be variability in how people report that, in what segments of the heart, what portions of the heart, what thickness of the heart, all of that. So it is very maddening to try to interpret these across different institutions, and even honestly within one institution, if there's variability in different readers. So this is something that Action is also trying to work at. While Action is very committed towards the data side of this, we're also committed towards just cleaning up the work in general. So we actually have three sort of harmonization projects we're working on. One is a harmonization related to advanced imaging. And so we have leaders from various organizations, including ourselves, Cincinnati, John Soslow, and others who are really working at trying to create one MRI protocol that people can mostly agree to, and also hopefully similar reading then could come from that as well. That'll help clarify the data that we're collecting and clarify patients' interpretation as well. The other two harmonizations that we're working on also include how to better assess the rhythm side of dystrophinopathies, as well as certainly how to address the medication side of things as well, what medications we have available to us now.
Well, and then first of all, I think we could talk about the heart all day, but one of the real risks and one of the worries of parents is if this heart gets to be at real risk of completely failing, there are devices like VADs, which just sounds a little frightening to many. And then the worry that if they need a transplant, Duchenne in particular has often been refused transplant. Can you speak to the devices a little bit and the policy around transplant?
Absolutely. So we are so blessed to live in a time of just advancing medical technology in so many realms. Gene therapy is, of course, one side of that. Mechanical circulatory support or ventricular assist devices is yet another. So we now have what we call implantable, durable ventricular assist devices. The one that is essentially the only one on the market at the moment this time is called the HeartMate 3. And this is a device which can significantly augment the cardiac output of the heart. And it is a mechanical device, and it is a big cardiac surgery. And but with it, in the best case scenario, a patient's life span and quality of life can be greatly augmented. And from personal experience with patients of mine, as well as patients I've met at meetings and throughout the country, we know that this device in the correct patient can work and do wonders. Anecdotally, our longest device patient is now 4 years and running, and doing great at home and overall with a really good quality of life. I should mention that we've looked at this within the Action Network as well, because of the intersection with both ventricular assist devices as well as cardiomyopathy patients of muscular dystrophy diagnoses, and we'll be soon publishing in the Journal of Heart and Lung Transplantation our initial experience of almost 20 patients with muscular dystrophies, different subtypes, largest being dystrophinopathy patients, with an overall reasonable outcome, meaning that they've done well, that they've been able to be discharged, go home, and in some cases be transplanted. So the caveat to that is picking the right patients and having these clear and open communications with our patients about what is or is not possible. So every patient that comes before us should not be considered a candidate for every therapy, because we don't know what a patient wants. We don't know exactly the degree of medical and technological reliance some families may wish to have and versus may wish to not have. And there are a lot of risks to surgeries, of course, and any surgery and major stressor to our body can, of course, lead to decreased respiratory strength, decreased other muscle strength, and lead to some setbacks. So this is where, as we continue to increase our experience, we can learn a little bit better and say, hey, this is the subtype of population that does do better. This is the subtype of population that does not do as well. And so this is the same answer for consideration for heart transplant as well. I personally do not believe that the diagnosis of Duchenne muscular dystrophy is by itself is a contraindication to heart transplant. Now, you may ask 20 different cardiologists their response to that question, and you probably will get 20 different answers. But again, there are patients who clearly will benefit and are clearly can undertake a transplant. And then there are patients who clearly would be unsafe to undertake a transplant. And finding that middle ground of where that can be an acceptable set of risks that can still lead to a really nice quality of life and quantity of life for that patient is an ongoing debate, and something that we're going to continue to struggle to move the needle with. Having undertaken at least 2 dystrophinopathy related transplant patient care at Nationwide, I can tell you that it is, while it is tough, that's our job, is to do the tough things and think about it with families, provide that counseling, and make that decision together. And when it can be done, it can be done well, but it can, like I said, it can be tough. So as we continue to gain experience with ventricular assist devices and to a lesser extent transplant, I think we're going to be able to spread that knowledge also much more easily through ACTION and our more regular meetings with the cardiac community taking care of these patients. One last thing to note there is with these ventricular assist devices, we've now reached an era where some of these devices, certainly in the adult population, have been running for greater than a decade. And in a best case scenario for a heart transplant in a young adult, you are sometimes talking about 15 to 20 years of life after a heart transplant. And so we're nearing the era where a ventricular assist device may be of similar utility to a family as a transplant. So there might be a growing indication for VADs into the future as well.
Well, first of all, that's music to my ears. My own boys died of heart failure, and I had so hoped that we could give them more time by some way, somehow. And so I'm really pleased with the Action Network, really thankful to you for all you're doing with Cincinnati, with all of your colleagues. If just as someone is viewing this, if they're going to an institution with their cardiologist and they ask, is your cardiologist associated with this network? How can they sync that cardiologist that may not be connected with the Action Network?
That's a great question. So we have 2 websites, the actionlearningnetwork.org and then myactioneducation.org. Action Learning Network is more clinician oriented, but has some nice patient stories and has easy ways to communicate and connect with us. Myactioneducation.org is another great website that provides a lot of patient and oriented education on the open to the public side of things, and can be a nice place for physicians of other groups to connect with us as well. So those are websites would be the best places to start, and you can communicate with us. We have a really dedicated team of admins and program coordinators who work with Action, who are amazing and will get back and communicate with teams at the ready. And just to also state is that any of the materials that we're making within Action aren't things we're trying to hold to ourselves. We're hopeful that as we get more and more of these sort of harmonization type documents written and reviewed by us within the larger Action team, that we'll be able to take some of these towards publication and put some of that information out there for broader consumption as well.
Good. Well, Deip, I can't thank you enough. We are so really interested in the heart and making sure these hearts are strong, and these young men and women who have cardiomyopathy and Duchenne or the dystrophinopathies live long, strong lives. So thank you very much for joining us, and I hope to continue the conversation very soon.
Thank you so much for having me. Have a great day.
Thank you. You too.